Welcome to Bookfulness, the deep dive dedicated to giving you the insights and clinical context you need. I'm your guide, and this is episode 34.
Hi, everyone. In our last deep dive, we really got into the weeds with the head, didn't we? Covered the cranium, face, scalp, meninges, basically the protective layers from Chapter 8.
We did. It was intense, laying down that structural foundation. But now, as promised, we're making a big shift, a geographical one, you could say.
Definitely. We're moving down, way down.
From the top floor right down to the foundation that carries everything, we're tackling the lower limb.
That's right. Today is all about Chapter 7, from the source material. Our mission really is to unpack the whole system, how it's built, how it moves us, specifically focusing on the hip, thigh, and leg.
So architecture, movement, specifically gait, and importantly, the nerves and vessels that keep it all running.
Exactly. And also looking at where things can go wrong, the clinical correlations, the common injuries. It's about understanding the engineering, both its strengths and its, well, failure points.
Sounds like a plan. Structure, function, and clinical relevance. Where better to start than right at the beginning how this limb even forms?
Okay, development. If you look back at the embryo, the limb buds appear pretty early.
Right. The source material compares upper and lower. Upper limb buds pop out first, around week 4, from C5 to T1 segments.
Correct. Then the lower limb buds, they lag a bit, appear about a week later, so week 5, and they're linked to the L2 to S2 spinal segments.
But it's not just about timing or location, is it? There's this fundamental difference in how they orient themselves. The book calls it the torsion paradox.
Ah, yes, the torsion paradox. It sounds dramatic, but it's absolutely critical. Both the upper and lower limbs rotate 90 degrees around their long axis as they develop.
90 degrees. Okay.
But, and this is they rotate in opposite directions.
Opposite. How so?
The upper limb rotates laterally, or outwards, by 90 degrees.
Yeah.
If you think about your own arm, your elbow ends up pointing backward, and the thumb side, the radial side, is lateral in the anatomical position.
Okay, I can picture that. So the lower limb does the opposite.
Exactly. The lower limb rotates medially or inwards by 90 degrees.
Medially, inwards. So what does that mean for the final structure? How does that play out?
Well, functionally, it changes everything. That medial rotation brings the knee joint, which initially faced kind of sideways, to point forwards or cranially.
Right, so you can bend your knee and walk forwards.
Precisely. And perhaps even more significantly, it causes what's described as permanent pronation of the leg and foot. This orients your big toe, the hallux, medially.
And that positioning, that inward twist, it determines where the muscle compartments end up, flexors versus extensors.
Absolutely. It's why your main knee extensors, the quadriceps, are on the anterior side, and your main knee flexors, the hamstrings, are posterior. It fundamentally adapts the lower limb for its main jobs: propulsion, stability, bearing weight. Completely different from the upper limb, which is adapted for grasping and manipulating.
Makes total sense. Function dictates form, starting right from that early twist. Okay, let's move to the main structural pillar then, the femur. Longest bone, strongest bone.
It is an incredible piece of biological engineering built to withstand huge compressive forces. Clinically, though, we often focus on a couple of key landmarks you can actually feel.
The trochanters.
Yes, the greater trochanter, laterally, that big bump on the side of your hip, it's vital for palpation because it's where major hip abductors and rotators attach. And then there's the lesser trochanter, more medial and posterior, the anchor point for the iliopsoas, your primary hip flexor.
Powerful muscles attaching there. But the source material, particularly the clinical boxes, spends a lot of time on a specific weak point. The femoral neck.
Ah, yes, the femoral neck fracture. This is a huge issue in orthopedics, especially in older adults.
Why is the neck so vulnerable? It connects the strong head to the strong shaft.
Several reasons. First, structurally, it's simply the narrowest and therefore mechanically weakest part of the bone. Second, and maybe more importantly, look at its angle. It joins the shaft at quite a marked angle. It's not a straight continuation.
So the line of weight bearing doesn't go straight down the neck?
Exactly. Weight comes down through the femoral head and then has to transfer across this angled, relatively thin bridge of bone to the shaft. That concentrates stress right at the neck, especially during impact, like a fall. And
then you add factors like osteoporosis,
which disproportionately affects older women, thinning the bone and making it even less able to withstand those stresses. So yeah, osteoporosis dramatically increases the risk.
What happens clinically when it fractures? The book mentions instability and shortening.
Right. These fractures, whether they're transcervical right through the neck or intertrochanteric between the trochanters, they're almost always unstable. The reason is muscle pull.
The big hip muscles.
Yeah, the powerful gluteals, the iliopsoas, the adductors, they all attach around the hip joint. When the bone breaks, these muscles go into spasm and pull on the fragments. This often causes the distal fragment, the shaft, to displace upwards and rotate outwards, leading to that classic sign of a shortened and externally rotated leg. Sometimes the fragments even get jammed together, what we call impaction.
That sounds bad enough structurally, but the text highlights a really serious complication, particularly with fractures inside the joint capsule. Vascular risk.
This is the critical point. The blood supply to the femoral head itself, it's precarious.
Precarious how?
Most of the blood, especially to the crucial weight-bearing superior part of the head, comes from the retinacular arteries. These are tiny branches, mainly off the medial circumflex femoral artery. And here's the problem. They run up along the femoral neck, but they run inside the fibrous joint capsule.
Inside the capsule. So if the neck fractures inside the capsule, an intracapsular fracture.
Those delicate retinacular arteries are very likely to be torn or disrupted.
And if the blood supply is cut off.
The bone tissue dies. It leads to a vascular necrosis, or AVN, sometimes called aseptic necrosis. The femoral head essentially collapses over time because its living structure is compromised.
So even if the fracture bone heals, the joint might be doomed because the head died?
Precisely. This often means the patient ultimately needs a hip replacement, either partial or total, even if the initial fracture wasn't severely displaced. Understanding that vascular anatomy, the vulnerability of those retinacular arteries, is absolutely key to managing these injuries. It makes intracapsular femoral neck fractures one of the most concerning injuries in orthopedics.
Wow. Okay. High stakes indeed. Let's move down the leg. Tibia and fibula. What are the key clinical takeaways there from the source?
The tibia, being the main weight bearer, it's prone to overuse injuries. The classic one is the stress fracture.
Often called march fractures, right?
Yeah, historically linked to military recruits doing lots of marching without being conditioned. But you see them in anyone who rapidly increases their impact activities, new runners, hikers tackling long distances unprepared. It's typically a hairline fracture in the inferior distal third of the tibial shaft. Basically, repetitive micro damage outpaces the bone's ability to repair itself.
Makes sense. What about the fibula? It's the thinner bone on the lateral side. Doesn't bear much weight directly.
Right. Its main roles are muscle attachment and forming the lateral part of the ankle joint, the lateral malleolus. It provides stability there. When the fibula itself fractures in isolation, it typically happens a bit higher up. The source says about 2 to 6 centimeters proximal to the tip of the lateral malleolus.
But often it breaks as part of an ankle injury, doesn't it?
Very commonly,
Right.
especially with severe twisting injuries. If you roll your ankle inwards violently, what we call excessive inversion, you can tear the lateral ankle ligaments. But the force can be so great that it actually pulls on the fibula and shears off the lateral malleolus. Sometimes it's described as an avulsion fracture, but it can also be a direct shear fracture.
A combined ligament and bone injury. Nasty.
Definitely. It destabilizes the whole ankle joint.
Okay, moving right down to the foot itself. The source mentions metatarsal fractures.
Yeah, the long bones of the foot. These can break from direct trauma. Dropping something heavy on your foot is a common cause. Or, like the tibia, they can suffer from fatigue or stress fractures, especially in runners or dancers.
But there's one specific metatarsal injury highlighted, isn't there? The fifth metatarsal.
Ah, yes, the avulsion fracture of the tuberosity of the fifth metatarsal. This is a very specific injury pattern.
What causes that? It's not direct impact usually, is it?
No, it's usually indirect force. It happens during sudden violent inversion of the foot, think landing awkwardly in basketball, or a quick pivot in tennis.
So, like the ankle inversion injuries we just discussed.
Exactly the same mechanism. As the foot inverts sharply, the fibularis brevis muscle, sometimes called peroneus brevis, which attaches to that prominent tuberosity on the base of the fifth metatarsal, contracts powerfully, trying to pull the foot back outwards, invert it, and resist the inversion.
Like a reflex action to protect the ankle.
Sort of, yes.
Right.
But if the inversion force is too strong and the muscle contraction too sudden and violent, the tendon literally pulls a fragment of bone off its attachment point at the tuberosity.
An avulsion. Muscle power overcoming bone strength.
Precisely. It's a classic sports injury mechanism. So you see, part one really sets up the vulnerabilities, that developmental twist setting the stage, the critical vascular supply in the femoral neck, and these specific fracture patterns linked to biomechanics and overuse.
Right. Establishes the hardware and its potential weak points. Now, let's see how this hardware actually works. How do we stand and move? Part 2. The mechanics of posture and gait.
Okay, posture. Standing upright, it seems like it should require constant effort fighting gravity.
Yeah, you'd think your leg muscles would be firing all the time just to keep you upright.
But the body is remarkably efficient. The source refers to the stand-easy position, which relies heavily on passive structures.
Passive, meaning not active muscle contractions.
Largely, yes. When you stand relaxed, your hip and knee joints tend to be fully extended. In this position, the joints are stabilized, almost locked, by strong ligaments.
Which ligaments are key here?
At the hip, the really important one is the iliofemoral ligament, sometimes called the Y ligament of Bigelow. It's incredibly strong and prevents the hip from hyperextending. At the knee, the cruciate ligaments and the collateral ligaments provide stability in full extension.
So the ligaments are taut, taking the strain, meaning the big muscles can relax.
Exactly. Your powerful glutes and quads aren't constantly firing just to hold you up. They're largely quiescent, saving significant energy. It's a very efficient design.
That's amazing. But surely something must be working. We don't just stand there like statues.
True. The weak link, or rather the point requiring active control, is the ankle.
The ankle, why there?
Because your body's line of gravity, the vertical line through your center of mass, typically falls slightly anterior to the axis of the ankle joints.
Anterior, so in front of the ankle joint, meaning gravity wants to pull us
Forward. It creates a constant tendency to fall forward at the ankles.
Ah, okay, so we need to counteract that.
Correct. And that requires intermittent slight contraction of the muscles in the posterior compartment of the leg, primarily the calf muscles, the gastrocnemius and soleus. They perform slight plantar flexion, pulling you back just enough to maintain balance.
So that feeling when you stand still for a long time, that ache in your calves, that's them working.
That's largely it. They're constantly making small adjustments to stop you from toppling forwards. It's the main active muscular work required for quiet standing.
Fascinating. Okay, so that's standing. Let's get moving. The gait cycle, walking.
The gait cycle is biomechanically just beautiful, complex but incredibly efficient. The source breaks it down simply into two main phases.
The stance phase and the swing phase. Stance is when your foot is on the ground.
Correct. That's about 60% of a normal walking cycle. It's when the limb is supporting weight. The other 40% is the swing phase, when the foot is off the ground and the limb is advancing forward.
60-40. Seems straightforward enough. But the source emphasizes something called eccentric contraction as being crucial.
Ah, yes. Eccentric contraction. This is absolutely key to smooth, controlled, and non-damaging locomotion.
Can you remind us what eccentric means again? It's not shortening the muscle, right?
Right. Concentric contraction is when a muscle shortens as it generates force, like lifting a weight. Eccentric contraction is when the muscle is active, generating force, but it's lengthening at the same time.
So it's acting like a brake, controlling movement.
Exactly. It's for deceleration and shock absorption. Think about it during walking. Take heel strike, the moment your heel first hits the ground.
Okay.
Gravity wants to pull your forefoot down immediately, slapping it onto the ground. That would be jarring and inefficient, a condition called foot drop, if the muscles are weak.
Right. So what stops the slap?
The tibialis anterior muscle in the front of your shin. As soon as your heel strikes, tibialis anterior contracts eccentrically. It controls the descent of the forefoot, smoothly lowering it to the ground. It absorbs the shock and manages the transition into the foot flat part of stance.
Ah, okay. A controlled lowering. And this eccentric braking happens elsewhere, too. The source mentions the hip and knee during swing phase.
Yes, absolutely crucial there, too. Think about the end of the swing phase, what's called terminal swing. Your leg is swung forward, and it's about to hit the ground again.
It's got momentum.
A lot of momentum. If there were no brakes, your knee might snap into hyperextension, and your foot would swing too far forward, landing awkwardly.
So what applies the brakes?
The hamstrings, your posterior thigh muscles. During terminal swing, the hamstrings contract eccentrically. They are lengthening as the knee extends and the hip flexes, but their contraction slows down that extension and flexion. They decelerate the limb, ensuring it's positioned correctly and ready for a controlled heel strike.
So eccentric control is everywhere, smoothing out the landing, controlling the swing.
It's fundamental to absorbing shock and making gait efficient and non-traumatic to the joints. Without it, walking would be a series of jarring impacts.
Okay. Now, walking isn't just about moving forward and back. When you're in the stance phase on one leg, the other side of your body wants to droop, right? Pelvic stability.
Yes, this is critical during the single support phase, which is a major part of stance. When, say, your left leg is swinging forward, all your body weight is temporarily balanced on your right leg.
Gravity would want to pull the unsupported left side of the pelvis downwards.
Correct. If that happened significantly, you'd get a pelvic drop on the swing side, leading to a characteristic limp or waddle. This is known clinically as the Trendelenburg sign if it's pathological.
So what stops the pelvis from dropping normally?
The hip abductor muscles on the stance side. So in our example, the gluteus medius and gluteus minimus muscles on the right side contract strongly.
But they're attached to the femur, which is fixed on the ground at that moment.
Exactly. So instead of moving the femur outwards, abducting the thigh, they pull the pelvis down towards the fixed femur on the stance side. This action effectively keeps the pelvis level, preventing the swing side from dropping significantly.
That's clever. The muscle action is stabilizing the core by pulling on the fixed limb.
It's a crucial stabilizing mechanism. Weakness in these muscles or damage to their nerve supply, the superior gluteal nerve, leads to that gait abnormality.
Okay, one more point on muscles and locomotion. The source makes an interesting distinction between the gluteus maximus and the hamstrings in terms of when they work.
Yes, this is about energy efficiency again. The gluteus maximus is, well, massive. It's the most powerful extensor of the hip.
You'd think it would be working hard during walking, extending the hip to push off.
You might think so, but during normal, level, casual walking, the gluteus maximus is surprisingly quiet. It doesn't contribute much to hip extension.
Really? So what is extending the hip then?
The hamstrings, the semitendinosus, semimembranosus, and the long head of biceps femoris. They are the primary hip extensors used during regular walking speed on level ground.
So the gluteus maximus saves its power
for more demanding tasks. It kicks in powerfully when you need forceful hip extension. Things like rising from a seated position, climbing stairs or a steep hill, running or jumping. It's reserved for high power output while the hamstrings handle the routine work.
Another example of efficient load sharing. Good to know. Before we leave movement, let's quickly touch on friction injuries. The source mentions bursitis.
Right. Bursae are these little fluid-filled sacs located where tendons or muscles glide over bone or where skin moves over bony points. They're there to reduce friction.
But they can get inflamed.
If they're subjected to excessive or repetitive friction or pressure, yes, they become inflamed, swollen, and painful. That's bursitis.
And the two key examples in the lower limb area.
Trochanteric bursitis is a common one. This involves the bursa overlying the greater trochanter, that bony prominence on the side of your hip. It often gets irritated by repetitive movements like running or stair climbing, especially if the iliotibial band running over it is tight. The pain is typically right over the trochanter but can radiate and down the lateral thigh.
Okay. And the other one mentioned is ischial bursitis.
Yes, this affects the bursa that sits between the ischial tuberosity, your sit bone, and the overlying gluteus maximus muscle.
So, related to sitting.
Exactly. It's often caused by prolonged sitting on hard surfaces or repetitive friction during activities like cycling or rowing, where you're putting pressure on those sit bones. It causes pain right at the base of the buttock.
And clinically, the source notes that the ischial tuberosities are important pressure points, too.
Critically important, especially in immobile patients. Because they bear the body's weight during sitting, they are very common sites for pressure sores or decubitus ulcers to develop in debilitated individuals who can't shift their weight regularly. That bursa inflammation is one thing, but skin breakdown over the bone is a much more serious issue.
Got it. Okay, so we've covered structure, weak points, and the mechanics of movement and stability. Let's dive deeper now into the hidden pathways, the nerves and blood vessels, and connections to the trunk. Part 3.
Right, let's start in a really important and somewhat vulnerable space, the popliteal fossa.
That's the diamond-shaped area behind the knee joint, right? Filled with fat, but packed with crucial structure.
Packed is the right word. You've got the main nerve, artery, and vein for the lower leg passing through here, and their arrangement is specific and clinically relevant.
How are they arranged? Is there an easy way to remember the order from superficial to deep?
There is. Think about what's closest to the skin when you feel behind your knee and what's closest to the bone. The most superficial or posterior structure is the tibial nerve.
Okay, nerve first.
Just deep to the nerve or anterior to it is the popliteal vein.
Nerve, then vein.
And the deepest structure, lying right on the posterior aspect of the femur and the knee joint capsule, is the popliteal artery.
Nerve, vein, artery. Superficial to deep. NVA, posterior to anterior.
Exactly. Knowing that order is vital for surgery or interpreting imaging in this region, the artery is the most protected, being deepest, but also the hardest to get to.
And being the main artery across the knee, blood flow is critical, especially since the knee bends so much.
Which is why the genicular anastomosis is so important.
Anastomosis, that means connections between vessels, right? A network.
Precisely. The popliteal artery gives off several named branches, the superior, middle, and inferior genicular arteries, medial and lateral pairs. These arteries form a rich, interconnected network around the entire knee joint.
Like a bypass system.
Essentially, yes, it provides collateral circulation.
Hmm.
If the main popliteal artery gets temporarily kinked or compressed, for example during prolonged kneeling or deep knee flexion, this network ensures that blood can still find alternative routes to reach the lower leg and foot. It's a vital backup.
Makes sense. Now, the popliteal artery pulse. Given how deep the artery is, how do you actually feel it?
It's tricky if the knee is fully extended because the overlying popliteal fascia and hamstring tendons are taut. The standard technique is to have the patient lie down, either prone or supine, and passively flex their knee to about, say, 30 or 40 degrees.
Flexing relaxes the tissues.
Yes, it relaxes the fascia and muscles, allowing you to press your fingers firmly into the fossa, usually aiming towards the midline or slightly medial, to feel the pulse against the back of the distal femur or proximal tibia. It requires firm pressure.
Okay. And what happens when things go wrong in this fossa? The source mentions aneurysms.
A popliteal aneurysm, which is an abnormal ballooning or dilation of the popliteal artery, is actually one of the more common peripheral artery aneurysms.
And because everything is so tightly packed in there.
Exactly. The aneurysm can expand and compress adjacent structures. Most significantly, it can compress the tibial nerve, which lies just superficial to it.
So an artery problem presents as a nerve problem.
Often, yes. The patient might complain of pain, tingling, or numbness, not just behind the knee, but referred down the distribution of the tibial nerve, so into the calf, the sole of the foot, or around the medial ankle. It can easily be mistaken for sciatica or another nerve root issue if you don't consider a popliteal aneurysm.
Good clinical pearl. Okay, let's broaden out from the knee and think about the sensory supply to the whole limb. The dermatome map is complex, but are there key areas or nerves we should focus on from the source?
We can simplify it a bit by looking at the major segmentum contributions. Roughly, the L2, L3, and L4 nerve roots supply the skin over the anterior and medial aspects of the thigh. Key named nerves carrying these fibers include the lateral cutaneous nerve of the thigh, mostly L2, L3, and the anterior cutaneous branches of the femoral nerve, L2, L3, L4.
Okay, L2, L4 for the front and inner thigh. What about lower down the leg and foot?
That brings in L4, L5, and S1. These segments cover the anterolateral aspect of the leg and the dorsum, top of the foot. The nerves responsible here are primarily the superficial and deep fibular or peroneal nerves, which are branches of the common fibular nerve.
And the back of the leg and thigh?
That's primarily S1, S2, and S3. The large posterior cutaneous nerve of the thigh covers the skin on the back of the thigh down into the popliteal fossa, and S1 is particularly important for the lateral side of the foot and much of the sole.
Speaking of the sole of the foot, the source mentions a very clear nerve division there.
Yes, the plantar surface, the sole, has a remarkably distinct sensory innervation pattern. It's divided between the medial plantar nerve and the lateral plantar nerve, both branches of the tibial nerve.
Kind of the dividing line.
It's surprisingly precise. Draw an imaginary line longitudinally down the sole that splits the fourth toe in half. Everything medial to that line, the medial 3½ toes and the corresponding sole, is supplied by the medial plantar nerve. Everything lateral, the lateral 1½ toes and the lateral sole, is supplied by the lateral plantar nerve.
That's incredibly useful for testing sensation and localizing nerve injuries in the foot. A very clear boundary.
It really is one of the more reliable anatomical boundaries for sensory testing.
Okay, finally, let's connect the lower limb back up to the trunk. The source highlights a few important clinical conditions where structures cross between the abdomen, pelvis, and the thigh. First, the psoas abscess.
Right. This involves the psoas major muscle, the big hip flexor that runs from the lumbar vertebrae down to the lesser trochanter of the femur.
And it has a fascial sheath around it.
Yes, a dense fascial sheath. The clinical relevance is that infections, particularly tuberculosis, TB, affecting the lumbar vertebrae, known as Pott's disease, can create an abscess that tracks downwards within this psoas sheath.
So the infection starts in the spine but travels down the muscle.
Exactly. It follows the path of least resistance within the fascia, eventually emerging as a swelling in the groin region, usually just below the inguinal ligament in the proximal thigh.
So it could look like a groin hernia or something else originating locally.
It certainly can. It might present as a tender swelling there, and without understanding this potential pathway from the abdomen or spine, the diagnosis could be missed. You need to consider the possibility of a psoas abscess tracking down.
Good point. Second connection, femoral hernias.
Femoral hernias occur when abdominal contents, usually intestine or omentum, protrude through the femoral ring and into the femoral canal, which lies just medial to the femoral vein in the upper thigh.
The source says they're more common in females.
Yes, significantly more common in women, likely due to the wider shape of the female pelvis, which might make the femoral ring slightly larger or configured differently. Although overall, inguinal hernias are much more common in both sexes.
But femoral hernias have a higher risk associated with them, strangulation.
That's the main danger. The femoral ring, the opening the hernia passes through, has very rigid, sharp boundaries. The inguinal ligament above, the lacunar ligament medially, the pectineal ligament on the pubic bone below, and the femoral vein laterally.
Not much give there.
Not at all. So if a loop of bowel pushes through, these rigid edges can easily compress the neck of the hernia sac, cutting off the blood supply to the contents. This is strangulation, and it's a surgical emergency because the trapped bowel can quickly become necrotic. The risk is much higher than with typical inguinal hernias.
Makes sense. And the final point ties into surgery for these hernias. The accessory obturator artery.
This is a really important anatomical variation for surgeons operating in the groin.
What is it exactly?
Normally, the obturator artery arises from the internal iliac artery within the pelvis. But in about 20% of people, according to the text, the obturator artery, or a large branch replacing it, arises instead from the inferior epigastric artery, which comes off the external iliac.
Okay, an alternative origin. Why is that dangerous?
Because this accessory, or aberrant obturator artery, coming from the inferior epigastric, has to cross the pelvic brim to get to the obturator foramen. And very often it runs across or very close to the medial margin of the femoral ring, right near that sharp lacunar ligament.
So right where a surgeon might be cutting to release a strangulated femoral hernia.
Precisely. If this variant artery is present and the surgeon isn't aware or careful, it can be easily cut during the hernia repair, especially when trying to enlarge the tight femoral ring.
And cutting an artery there
can lead to significant, hard-to-control bleeding. The source even mentions its old, rather grim nickname, the coronum mortis, or crown of death, highlighting the historical danger associated with injuring it during pelvic or hernia surgery. It's a classic example of why surgeons need detailed anatomical knowledge, including common variations.
Wow. A potentially lethal variation in 1 out of 5 people. That really underscores the importance of knowing this anatomy inside out.
It absolutely does.
Okay, that brings us nicely to the end of our journey through the lower limb for today. We started with how it twists into position during development.
Covered the strengths and critical weaknesses of the femur, especially the neck.
Looked at common fractures in the tibia, fibula, and foot.
Analyze the efficiency of standing posture and the complex controlled mechanics of the gait cycle, emphasizing eccentric contraction.
Discussed muscle actions, like the gluteus medius stabilizing the pelvis and the division of labor between gluteus maximus and hamstrings.
Touched on friction injuries like bursitis.
Navigated the vital structures in the popliteal fossa and their clinical implications, like aneurysms.
Mapped out the key sensory nerve distributions.
And finally, connected the limb back to the trunk via pathways relevant to psoas abscesses, femoral hernias, and that dangerous accessory obturator artery.
It's a huge topic, but hopefully we've hit the key structural, functional, and clinical highlights from Chapter 7. The lower limb is truly engineered for support and locomotion, but like any complex machine, it has specific points of vulnerability. ##C outro.
So in this deep dive, we really focused on the lower limb's mechanical stability, from its unique developmental rotation to the passive supports in standing. We dissected the efficiency of the gait cycle and highlighted crucial clinical correlations, especially around fractures and vascular supply.
We saw how structure dictates function, but also how specific anatomical arrangements like the blood supply to the femoral head or the contents of the popliteal fossa create inherent risks.
Definitely. A lot to digest there on the foundations of movement. Now, next time, we're heading back up again. We'll return to the head, building on our earlier explorations, to analyze the anatomy of the regions of mastication and the oral cavity.
That's right. We'll be diving into the details of the teeth, the tongue, its complex musculature and innervation, the palate, and all the muscles involved in chewing, swallowing, and the initial stages of digestion. It's another area of intricate anatomy with huge functional importance.
Sounds fascinating. We hope you'll join us then for that discussion.
Thanks for listening to Bookfulness.